So, how do somatoform and conversion disorders show up in the field? From an EMS perspective, these calls often come in looking like any other high priority medical call because the symptoms can be dramatic. Here are some common ways such patients might present to us. Seizure calls. We may be dispatched for a seizure, where the patient is actively convulsing or post seizure when we arrive. The catch is, if it's a psychogenic non epileptic seizure, PNES, the presentation might have subtle differences from an epileptic seizure. We'll detail those in a case example. But on face value, it looks like a seizure. Uncontrolled shaking, maybe eyes closed, perhaps no tongue biting or incontinence, but we don't always know that up front. Sometimes such a patient has a history of seizures that are not responding to typical medications, which is a red flag for possible PNES, stroke-like symptoms. A patient might suddenly not be able to move one side of their body or can't walk or speak, things that make us think stroke or neurological catastrophe. Yet in conversion disorder, those can happen due to stress. For example, a young person after a heated argument suddenly can't see or can't move their legs. We treat it as a possible stroke or TIA, but the details might not add up perfectly, like normal blood pressure, patient is 20 years old with no risk factors, etc. Chest pain or SOB. We also get a lot of calls for chest pain or difficulty breathing that end up being panic attacks or anxiety related somatic symptoms. The patient might be genuinely feeling chest tightness, tingling in the extremities, tachycardia from hyperventilation, etc., but they may be younger with low cardiac risk, and the scenario might involve emotional distress, like occurred during a panic. These are tough because chest pain always needs to be taken seriously, but we keep in mind anxiety can manifest this way. Unexplained pain. Patients with somatic symptom disorder might call for pain crises, whole body pain, or I'm in terrible pain and nothing helps. Yet physical exam is benign and vitals are stable. Or a patient insists they just know something is ruptured inside because of pain, despite no evidence. Some clues for EMS that a case might be somatoform in nature: history of frequent ER/EMS use. If dispatch alerts that this address or patient is a frequent flyer, or family on scene say, "We've been through numerous tests at hospitals and nothing is ever found," that's a sign. Extensive negative workups. The patient might outright tell you, "I've had every test and they always say I'm fine, but I feel awful." Documentation from prior discharges might list diagnoses like anxiety or medically unexplained symptoms. Known psychiatric history. Many, not all of these patients have a background of anxiety, depression, PTSD, or previous trauma. If a bystander or medical alert lists that, it can tip you off. For example, patient has PTSD and an anxiety disorder in the med list. Context and triggers. Often these episodes occur in the setting of emotional stress. Maybe the patient had an argument, got bad news, or is in a stressful environment and suddenly symptoms start. Bystanders might say they were fine until they started panicking about X. Emotional presentation. Sometimes the patient is extremely anxious, even panicky, like hyperventilating, crying, or expressing fear. "Please don't let me die, I know something is wrong." Other times, like in some conversion cases, the patient might seem oddly calm or detached given the severity of symptoms, which is the label indifférence we mentioned. It's important to emphasize these clues are not definitive. For example, just because someone has anxiety doesn't mean their seizure isn't real. And just because tests were negative yesterday doesn't mean something new can't happen today. But these factors raise our suspicion that we might be dealing with a somatoform case, which can guide us in how we communicate and perhaps avoid overtreating, or at least be mindful of not causing harm. When assessing a patient who might have a somatoform or conversion disorder, the number one rule is don't jump to conclusions. Always start by treating it as a potential genuine medical emergency until you are sure it's not. Rule out life threats. First, our priority is to not miss a real illness. Just because something could be psychosomatic doesn't mean it is. Pre-hospital personnel usually cannot definitively distinguish conversion reactions from organic illness in the field. Even neurologists can struggle in the ED. So we follow our protocols as if it's real. For a seizure call, that means managing the airway, giving benzodiazepine if it's prolonged, checking glucose, etc. For a stroke presentation, that means doing a neuroexam, checking blood sugar, and expediting transport to a stroke center. For chest pain, do your cardiac workup. The idea is that you treat and assess for the worst case scenario first. Gather history and context. While you're doing your exam and treatment, collect clues through history. Ask the patient or family, has this happened before? Often you'll find, yes, she's had episodes like this and the doctors never find anything, or he has these spells when he's very stressed. If the patient is new to you, look for medical alert cards or history and dispatch info. A history of similar episodes with negative workups or known diagnoses like PNES or somatic disorder can clue you in that this might not be a new stroke or seizure, but the recurrence of a functional issue. Also, ask about recent stressors. What was happening right before this started? If the family says we were arguing and suddenly she couldn't move her legs, that's notable. Or he's been under major work stress and now he's having chest pain. Psychological triggers in history don't prove it's not medical, but they are pieces of the puzzle. Also, medication history can help. Are they on anti anxiety meds, antidepressants, or antipsychotics? That hints at underlying psych issues. Are they on anti epileptic drugs without a clear epilepsy diagnosis? That might mean they have a history of PNES being treated as seizures initially, which happens often. About 25% of supposed epilepsy patients actually turn out to have PNES. Physical exam clues. As you examine, sometimes you find inconsistencies that suggest a non organic cause. For example, in a supposed stroke with one sided weakness, you might notice that when distracted, the patient can momentarily move the affected limb with normal strength. This is related to things like Hoover's sign, a test where you feel for pressure in one leg when they're told to lift the other, which can expose non organic paralysis. Or a patient who seems unresponsive but their pulse and breathing are normal and their eyelids flutter when you gently touch their eyelashes, a trick sometimes used to see if a coma is real or not. With seizures, as we discussed, organized rhythmic movements versus chaotic thrashing or lack of postictal phase are clues. If a patient's story is full of dramatic symptoms that don't line up anatomically, we consider a functional cause. However, I caution, these clues are for our internal suspicions only at this point. We do not confront the patient with them. Instead, we use these observations to quietly guide our management and to relay to the hospital. Avoid diagnostic labels in the field. We should never flat out tell the patient or family this is fake or it's all in their head on scene. Even if we are pretty sure it's psychosomatic, it's not our role to diagnose that. We maintain a supportive, non judgmental demeanor. In fact, even at the hospital, they often need video EEG or other tests to confirm conversion disorders, which can take years to diagnose definitively. So, in the field, focus on what you need to do medically and keep an open mind. The last thing we want is to dismiss a real emergency as just anxiety and have it turn out we missed a stroke or an MI. Use guidelines but with mindfulness. Follow all standard assessments, stroke scales, cardiac monitors, blood glucose, etc. As you gather results that are normal, that can reduce your index of suspicion for organic causes. For example, normal blood sugar rules out hypoglycemia, normal SpO2 rules out hypoxia as cause of seizure, etc. If everything is checking out fine and the patient is improving with simple measures like calming them, that leans towards a somatoform cause. Handling these patients is not just about the medical interventions, it's very much about how we communicate and behave toward the patient. Many somatoform patients have felt invalidated or accused in the past, so our approach can make a huge difference in their experience and cooperation. Here are key strategies. Stay calm and empathetic. Patients might be in extreme distress, screaming in pain, panicking, or unable to move. As the provider, maintain a calm presence. This has a dual benefit. It helps soothe the patient and it keeps the scene controlled. If a patient sees you calm, they often mirror that. Use a gentle tone of voice. Acknowledge their suffering. I see that you're in a lot of pain scared. I'm here to help you. Even if you suspect a psychological cause, their suffering is genuine. Therapeutic communication. This means using your words and body language as a tool to help the patient. Reassurance is key. Simple phrases like, you're going to be okay, we're not finding anything dangerous at the moment, stay with me, and we will take care of you can reduce anxiety. If the patient is hyperventilating or crying uncontrollably, try to coach their breathing. Let's slow down a bit. Breathe in slowly through your nose. Now exhale out of your mouth. Good. Keep doing that with me. This can help mitigate symptoms of panic and physical signs like tingling or dizziness from hyperventilation. Also, consider the environment. If a crowd has gathered, common with public seizures or dramatic events, try to move the patient to the ambulance or ask bystanders to give space. This reduces external pressure and potential embarrassment for the patient. Avoid negative actions. Never do things like shouting, snap out of it, or as unfortunately some old school responders did, saying, quit faking. Those are obviously harmful. Also, avoid those trick tests often mentioned. For example, some providers might be tempted to drop the patient's hand over their face to see if they move it, thinking if they don't smack themselves, they must be faking. These actions are not reliable and are demeaning. Even if you catch the patient doing something inconsistent, that's not going to help you treat them in that moment, and it certainly will destroy trust. Another thing, Do not administer placebo treatments like an injection of saline telling them it's a powerful drug. That is unethical and can break trust if they figure it out. Symptom management. Treat whatever symptoms or issues you find within your scope and guidelines. If a patient is writhing in pain, even if it might be psychological pain amplification, you can still provide pain management as indicated. If someone is in a prolonged psychogenic seizure or severe panic and is not settling with verbal coaching, consider pharmacological help. As noted, benzodiazepines, like midazolam or lorazepam, can be a helpful tool because they treat both true seizures and acute anxiety. If your protocol allows, giving a moderate dose can stop the physical manifestations and also relieve the emotional torment. Ensure safety. If the patient is thrashing or flailing, as in PNES, protect them from injury. Guide them away from furniture edges, use padding, avoid restraining unless absolutely necessary for safety. Restraint can escalate a conversion or panic situation. If restraint is needed, say a patient is hitting themselves or others, use soft restraints and have enough personnel to do it safely, and combine it with calming talk. Also ensure your safety and crew safety. Sometimes these calls can get chaotic, but in general, these patients are not typically violent toward others, unless extremely agitated from panic or delirium, which is less common in pure somatoform without drugs on board. Reassure and explain, professionally. Keep the patient informed. Your blood sugar is normal, that's good. We're checking your heart now, so far so good. This kind of running commentary in a soothing tone can ground the patient in reality and also subtly let them know that nothing catastrophic is obvious, which may calm them. However, balance reassurance with honesty. Don't promise nothing is wrong outright on scene. They often will think, but I feel something is wrong. Instead, say what you find. I don't see any signs of a stroke right now. Your strength is equal when I test your arms, which is great. Or, your heart monitor looks normal at the moment. This gives real data that might penetrate their panic a bit. Maintain patient dignity. These conditions sometimes make patients feel ashamed. Treat them with the same respect you would a patient with a diagnosed medical condition, because they have one, just a different kind. Small things help. Cover them if their clothes are messy from a seizure, ensure privacy when possible, address them by name, and don't discuss your personal theories about them in front of them or others at the scene. By handling communication and management in this compassionate, professional way, you not only potentially shorten the episode, but you also build trust. This means the patient is more likely to cooperate with transport and follow up. Also, if this is a frequent utilizer of EMS, a history of positive, empathetic interactions can actually reduce their anxiety on the next call. I know those medics won't judge me, which can, over time, help break the cycle of repeated crises. We will wrap up this lecture here. Join me in the next one to apply what we have learned to some patients you may encounter in the field. See you then.